ambulance are being given. And obviously, I think if it's available and it's most optimal, it's a cardiac ambulance with a attending pediatric intensity accompanying a child would be the most ideal situation. So any child having surgery below the age of 1 month is neonatal heart surgery, and more than 1 month and 1 year of age is infant heart surgery, and above that they're called as toddlers, and they come under the general heading of pediatric cardiac surgery. So just to give you a brief thing, was attempted early in the early 80s in the USA. And this expertise arrived in India in the early 90s when I began my training in this field. And by mid to late 2000s, results started to match world levels. And today, I think we are on par with anyone on the world, particularly in those centers which have got a good team and other good facilities to take care of these neonates with heart defects. So can a neonate have a successful open heart surgery? Yes, by all means. That's the level of expertise available now with members of a dedicated Children's Heart Center team. Neonatal cardiac surgeons, surgical corrections are commonplace today in big units. Most common surgeries done on neonates are arterial switch operations for transpositions, correction of obstructed total veins, correction of coarcted and hypoplastic arch, interrupted arches, first stage operation of small left ventricle or hypoplastic left heart syndromes, and shunts to increase the pulmonary blood flow in atresia situations. The cardiologist not to be left behind, the interventions commonly done are balloon valvotomies, aortic and pulmonary valvotomies, PDA stentings, ballooning of severe coarctation. This is just a sort of a bird's eye view of the common neonatal heart operations and interventions done in a busy unit. What are the results of neonates? Extremely good. Complete corrections always give much, much better results than palliations or stage repairs. And today, if you see the results of arterial switch for transposition, it is approaching 99%. So basically, the success rates can vary from 95 to 99% in most regions. So this is just for those who don't know what's the surgery and intervention. Surgery is an operation, heart-lung machine is used, heart surgery on the heart is performed. Once it is stopped, once the correction is completed, the heart is restarted. This is called as open heart surgery, and it's done by a pediatric cardiac surgeon with specialized operating rooms. Intervention is a lesser kind of operation done by passing fine catheters and into the neck artery under X-ray guidance, and valves could be dilated, stents could be placed, or holes can be closed. This is done in the catheterization laboratory or cath lab, and it's done by the pediatric cardiologists trained in interventions. So with this introduction of the neonatal heart surgery, I thought now we'll go on to the question answer sessions which have been posed to me. So the first question is, do platelet to lymphocyte ratio PLR and neutrophil to lymphocyte NLR have a predictive value on pediatric extracorporeal membrane circulation, ECMO? That's a good question, really, because both these PLR and NLR are inflammatory parameters. And as we know, as long as any of the extracorporeal circulation is going on, there is more and more inflammatory parameters being produced. So while it is cheap to measure this and know that there's inflammation going on, perhaps a trend value will be better than an individual number. So maybe a rising trend of a PLR or NLR may be of more value, indicating that there is an inflammation or if there's an associated infection than otherwise. Next question 2. What is the utility of steroid administration for pediatric heart surgery with the use of cardiopulmonary bypass? Current practice, no. There is no use for steroids in pediatric heart surgery in the use of cardiopulmonary bypass. We have gone through a full cycle here. Initially, we used to give methylprednisolone in cases where we are going in for total circulatory arrest. Even that has been discontinued. And addition of steroids or administration of steroids in cardiopulmonary bypass has given rise to very high post-op blood sugar levels. That's again a bad thing to have, more chances of infection, more chance of osmotic diuresis and all that. So therefore, steroids have more or less been given up as in the course of pediatric cardiopulmonary bypass. Next question 3. It is often said that the pediatric disciplines follow in a delayed fashion their adult counterparts. What's your opinion? Yes, they do. Particularly if you, including heart surgery, if you see it was started, though it started in congenital heart diseases, heart surgery began, open heart surgery began with the closure of an ASD. Then it moved on to coronary bypass. Kids were a little late in starting the smaller ones. The reasons are many, I think, because uh, adults, one, they're larger in numbers. And the other thing is most of the initial hardware were designed for adults and they had to be re-engineered to get to the kids. So, and plus our understanding of physiology had to be perfected with adults, and then we tailored and understood the kids' physiology. And also, I think adults so units are much more because of the numbers. Kids units are much less, and also these the hardware and the market forces will dictate the utilization of hardware. The availability of hardware is much less. So therefore, and including if you see of late now, the LVADs and the VADs which have been developed, basically it's all for adults, and it's only after a sizable experience with adults and mastering them that we are beginning to see the development of pediatric VADs. So certainly the answer to your question is pediatric disciplines do follow the adult experience. What are the complexities of fetal cardiac intervention and when is it indicated? Well, fetal cardiac interventions are a challenge. It's still not universally, I would say, available in the clinical arena. They're very highly specialized indications. Though on the plate, you see it should be easy because the placenta is there. It's as good as a Hartling machine. Everything is there, and then you can go and intervene in the baby. But then it's not, it's easier said than done. So the complexities of fetal cardiac interventions are many. One is the access itself, the fact that you have to work with an amniotic fluid around, and you have to hit the correct area which you wish to enter, and also the fact that your child is moving. And though it all sounds good in theory, the placenta taking care of the circulation, but a higher incidence of abortions and miscarriage after an intervention. So these are some of the important complexities which we see in fetal interventions. And most common intervention has been the aortic valvotomies, and one or two balloon pulmonary valvotomies have been attempted, but aortic valvotomies have been done to promote left ventricular growth. What are the screening procedures for fetal congenital heart disease? I would say there are two screening procedures. One is, of course, we have to see to it that is as uh, less harmful to the fetus as much as we can. So fetal echocardiography ultrasound is most important screening procedure which is there. And we wouldn't like to have any of the other imaging things because of the x-rays involved. Then, of course, we have the blood investigations where usually you find for Downs and other syndromes where you look out for a trisomy and Q22Q deletion, etc. So these are the basically the two investigations which we do for screening procedures for fetal congenital heart disease. What is the added value of 3D, 4D ultrasound imaging in fetal cardiology? Yes. So 3D imaging are very good, particularly to visualize the valves, the valve functions. And 4D, when we add real time to that, you have a real time 3D and 4D. So it all depends here, though we recognize the fact, at least in the postnatal transesophageal echoes and also in the transthoracic echoes, the 3D and 4D ultrasound imaging, the advantages, particularly in the valves. And uh, the challenge in fetal cardiology is to get good pictures, to get views. And we do know that 3D and 4D are important investigations, but in fetal cardiology, it all depends on image acquisition and then interpretation. Which case in particular are indicated in fetal cardiac? This is what I explained in a few moments earlier. Particularly, aortic valvotomy has been done on the premise that once you open the aortic valve, if it is stenotic, the forward flow of the blood helps the left ventricle to grow. So balloon aortic valvotomy are approaching through the left ventricle from the ventricular transthoracic approach has been done and has given good results in a few cases. And it has been done in Hyderabad and Cochin in India. And these kids have been followed up and there has been growth of the ventricle. Pulmonary valve is a little more difficult to approach, and though it has been done overseas, I'm not sure if any pulmonary valvotomies have been done in India. What is the Ozaki aortic valve replacement procedure? What is its success rates? Next question. Ozaki is a Japanese surgeon who designed this procedure, and it was basically a replacement of the aortic valve by treated autologous treated pericardium and making 3 leaflets just like a normal valve and implanting them in the respective aortic sinuses. So the technique is called an Ozaki aortic valve replacement technique. Now, this was actually done in 60 plus adult patients, and he reported pretty good results in these. The success rates were pretty good in the sense that at the end of 5 years, there was nearly about 85% of the patients had pretty good aortic wall function. But thereafter, it was maybe a little longer, it started to decrease. So with this enthusiasm, we also extrapolated this procedure to the children in not we as such, but many other units. After, at least in the bigger children, say 10 to 12-year-olds and teenagers. But then after the initial successes, the enthusiasm has worn off because in children, they don't seem to be doing as well as the adult patients. So currently, it is a form of aortic valve replacement which is available, but in children, it may not be a very good idea to do the Ozaki procedure. But perhaps in adults who are beyond the age of 60 years, it might still have a place in reconstruction of the aortic valve. What are the risk factors for mechanical aortic valve replacement? I think that is very important. And aortic valve replacement by mechanical valves is a very old procedure. We know many things about it. The first and foremost in the mechanical aortic valve replacement is the need for anticoagulation. And it's beyond doubt that anticoagulation has to be done. And so we tend to keep the INRs around 2.5 to around 2.5 in a case of aortic valve. And aspirin also is one of the recommendations to be given for mechanical aortic valve replacement with anticoagulation like warfarin or acetone. And the risk factors for these is first thing is bleeding problems, because the INR overshooting, you can have bleeding issues. Then the next is a clotting problem. The valve can just clot off, particularly if there's a pannus growth or if you find the INRs are not adequately kept or the child has outgrown the valve. So these are some of bleeding issues, then clotting issues. Infections, prosthetic valve endocarditis is a fearsome complication, and if it is done, the whole valve has to come out and it has to be redone. And then, of course, you have the issues of uh, some anything with a repeated change of the aortic valve. You can get aortic aorta issues. You can have dissections, very very rarely, though, but that has been described. So basically, the commonest problems are bleeding issues because of very high INRs. Sometimes, very rarely, people have bled in the head, giving rise to hemorrhages, then clotting, and infections. And then, of course, you have valve issues where, because of the uh, either the manufacturing defects or the wear and tear of the valve, sometimes you have disc embolizations and disc can get stuck, give rise to acute valve regurgitations. So these are the common problems with mechanical aortic valve replacement. Paravalvular leaks is also another issue which can progress or which can remain, and which can be managed nowadays to some extent by interventions, or it may need a replacement. Next question. It is true that maternal hyperoxygenation or in late gestation promotes the increase of fetal cardiac dimensions in hypoplasic left hearts. Yes, it is true. There has been a lot of interest in this maternal hyperoxygenation when it reduces the pulmonary vascular resistance, increases the pulmonary venous flow, it improves the left-sided return, and increases the LV dimensions and output into the aorta. Yes, there has been interest in that, and more so, it has also been seen that it's best done in the in the early part of the third trimester, and a few successful case reports have appeared where it has reduced and increased the size of the hypoplastic aortic arch and all that. 12. Next question. Between surgical aortic valvuloplasty and transcatheter balloon aortic dilatation, which is more suited for treatment of congenital aortic stenosis? Yes. So obviously, I think if you see from the patient standpoint and ease of procedure, a balloon aortic valvotomy is always the first port of call when you are asked to treat a congenital aortic stenosis. And balloon aortic valvotomy is a simpler procedure. It can be repeated uh, uh, many times if need be, and the only thing is, if you do a balloon aortic valvotomy, the chance of a repeat aortic valvotomy and the chance of another procedure needed is much higher than a surgical valvotomy. But then, it being a simpler procedure, scores over the surgery. The only risk of balloon aortic valvotomy is an acute aortic regurgitation, which may require emergency surgery. Because if you do an incomplete valvotomy, we can always go back and do a repeat valvotomy a little later. Surgical valvotomy, yes, it's a more extensive procedure, and it has to be done in indicated cases. Unicommissural valves with eccentric leaflets, surgical valvotomy is always better because it causes much less of aortic regurgitation after the valvotomy. Surgical valvotomy, the only advantage is that the repeat valvotomy incidence is much less compared to a balloon aortic valvotomy. But that is sort of balanced by the fact that it's a major procedure and a lot of other issues when compared to a balloon aortic valvotomy. But in these cases, when you find that the unicommissural valve, where you find that the commissure is not well defined, surgical valvotomy is a better procedure. Hybrid approaches combining treatment strategies of interventional catheterization and surgical techniques were initially confined to stage 1 palliation for infants with hypoplastic left heart syndrome and variants. What are the scenarios where these approaches are applied today? There are many instances, really. First of all, it's only now that we are getting hybrid theaters in India, and a lot many newer units have got hybrid theaters in India. So, in addition to the palliation for a hypoplastic left heart, the other areas could be One, in complex redos when areas cannot be reached, as in distal pulmonary arteries or collaterals or shunts, when in which case we can do a hybrid procedure with the cardiologist taking over the stenting and occlusion uh, uh, with plugs or devices, and the surgeon doing the complete correction. So these are the other areas: collaterals, distal pulmonary arteries, then dilatations, stenting in areas of narrowing, particularly in the pulmonary side, or even in coarctations where you find that a coarctation is treated and the other cardiac problem solved. There are some of the areas where hybrid theaters can be used, and both cardiologists and surgeons can work in the teams. Multimodality three-dimensional image integration is becoming more popular for cardiac imaging. Will this require higher radiation exposure for neonates? Yes, certainly. So that's why in neonates particularly, we try to think twice if we ask for all these CT scans and all these other multimodality imaging. And if we can get by getting the uh, information by ultrasound, that's the best. Or alternatively, if we have to get, maybe an MRI would be a better investigation than. But only thing is that require the child to be intubated and then the investigation done. What is the current status of the pumpkin trial evaluating the infant Yarwick against the Berlin heart? I'm sorry, I don't know the current results, but we do know that this is an ongoing trial between the Yarwick and the gold standard Berlin heart. But I'm not aware of any article which has come out in favor of either one in the pumpkin trial. I think it's still an ongoing trial because the last literature I've seen is in 2018 for this. What are the chances of developing aortic thrombosis? What are the chances of developing thrombosis in neonates using ventricular assist devices such as infant Yarwick heart? Possibly this might be less because the earlier incidences of thrombosis of the VADs in children has been a sort of an adult VADs put in them with low rates and the thrombosis was high. But it is anticipated that with infant Yarwick hearts, it should be less. So I think the pumpkin trial could throw more light on this. Can patients with levotransposition of the great arteries survive into their 80s without surgical corrections? Well, they can. Theoretically, they can. Though practically, we have had instances of these patients uh, uh, living well into their 60s. 80s, well, I don't know. They could live, but otherwise do have problems. And we know that the long-term history of L transpositions can be from the rhythm-wise. They can go into complete heart blocks, and they can develop left AV valve regurgitations. They can get ventricular dysfunctions. So if by some means a person is blessed with all this not coming up, they can certainly live to the 80s. But generally, all these problems catch up, and the patients may require something done, and the longevity gets reduced. How does Del Nido cardioplasia solution compare to Plegisol for use in neonates? Great. I think Del Nido cardioplasia is just great in neonates as compared to Plegisol. The advantage of these is that one, it has got procaine, which is lignocaine, which sort of is a membrane stabilizer, and you need to give cardioplasia just once for about 2 hours of cardioplasia time in at a temperature of around 24. So the chances of one repeated cardioplasia, the chances of air embolizations, the chances of myocardial edema is much less with Del Nido cardioplasia, and it seems to be the preferred one currently in neonates. What factors should a clinician consider while making the choice whether to delay cardiac intervention in very low birth weight infants with congenital heart defects? When I say very low birth weight infants, generally I would refer to below 2 kilos. So if though we have done arterial switches, we have done transfer the TAPVC corrections up to 1.5 kilos, 1.49 kilos, but still, I think below 2 kilos, the capacity of the child to tolerate the pump run, the capacity of the child uh, to do well, the inflammatory reaction of the pump run, the sepsis, and all this is much higher. And the results below 2 kilos are a shade worse than the one above 2 kilos. But having said that, the other issues are one, prematurity. Premature kids don't seem to do well with the Hartling machine run, and there's certainly a higher chance of risk. Sepsis is another thing which they are more prone to, and because the pump run is greatly immunosuppressive, and they're prone to all kinds of sepsis. Other thing we have to see also is the cerebral issues. Some of these children, they can have seizures, they can have hypoxia, how it's going to translate into the well-being of the child after a complex and a major cardiac surgery, possibly including circulatory arrest if that needs to be used. So CNS issues, septic issues, weight-wise, below 2 kilos, and association of other syndromes. Syndromic kids somehow seem to do far worse than a normal child who's just low birth weight. So these are some of the factors we need to factor in when we need to do an intervention in very low birth weights infants with congenital heart defects. Surgical management of left ventricular outflow tract obstruction in infants with right dominant unbalanced transitional AVSD poses difficulties. What are the ways to manage such a case? Well, these are some of the most challenging cases in congenital heart surgery. LVOTO with right dominant unbalanced AVSDs. What are the ways? Well, they have been, initially it was straight away, they were putting it into the Fontaine operations. And, but now with some of the experience accrued from Boston Children's Hospital about the development of the left ventricle, by controlling the ASD and by in a staged way, see if we can make that LV to develop, to grow in a neonatal age group and use it as for a biventricular repair. These thought processes has sort of come about, but the path is long, the path is arduous, and perhaps in any case of an unbalanced AV canal with a left-sided obstructive lesions leading to a hyperplastic left ventricle, maybe less than about 30% of the children can be trained to go into a biventricular repair. And even if they do go into biventricular repair, what's going to happen in the long term is open to question. So the experience on this is pretty limited, but otherwise, I think if we have to do it is a single ventricle pathway, well, we have to see that the AV valves are okay, they are not leaky, and we may have to band them initially and then take them onto the single ventricle pathway if that has been decided. So, so they are very challenging subset of cases. And as far as we can, we try to do a biventricular repair if it is feasible. But then, if many a time it is not, and we may have to take them into the uh, single ventricle pathway. And that too, if the left ventricle outflow tract obstruction is severe, well, they may have to undergo a Norwood-like procedure and then go on to a single ventricle pathway. Next question. What is the management protocol for a rare inflammatory myofibroelastic tumor of the mitral with systemic embolization in a child? Well, I think I've got very little experience with heart tumors, excepting perhaps the myxomas and a few cases in the outflow. I would say that this has to be according to the basics of tumor surgery in the heart, where you find that the indications for surgery would be if any of the outflow or inflow parts of the heart is obstructed, and if the heart is, if it's not obstructed, otherwise, I feel a conservative approach is far better. Surgical management of giant intraperitoneal teratoma encasing the coronary artery. What are the associated complications and complexities? Truly, I don't know. I mean, I have absolutely no experience with giant intrapericardial teratoma encasing the coronary arteries, but I guess common sense dictates that we have to protect the coronary artery and see if needs to be debulked or reduced it by radiotherapy if we can, and see to it that no harm befalls the patient by damage to the coronaries. What are the related risk factors and complications of low cardiac output syndrome after operation in children with congenital heart disease? Well, I think every child who has a complex congenital heart correction goes into a low cardiac output. The severity will depend on many things. It depends on the correction. It depends on the duration of aortic cross clamp. Depends on the on the duration of the bypass time. It depends on the type of myocardial protection that we have offered, whether the residual lesions are there or not. So, and the age of the child. The, so a lot of these factors determine the low cardiac output syndrome. So I think all said and done, it's first thing in the low cardiac output is the anticipation part of it. You have to anticipate and pick up the smallest of nuances of low cardiac output, which appears either like a rising base excess or you find that the core temperature peripheral difference is high, or you find that there is decreased urine output. And so there are some of the smaller, the subtleties of low cardiac output, which is has to be picked up, and the appropriate choice of inotropes. It is not that you always have to have a great pressure. It has to be, you have to see the filling pressures. So we have to put in filling pressure monitoring lines, which will also help us in heart rate management, temperature management, acid-base management, potassium management. All these are important in management of the low cardiac output in these patients. Complications of low cardiac output, yes. End organ function, end organ dysfunction is extremely important. Either it's the kidneys, which is the first most important thing, brain the next, and liver very, very rarely, particularly if there is very high RV pressures, which gives rise to a fontan, which very high PA pressures giving rise to back pressure effects on the liver and ascites. And so these are some of the things that we have to look out for. How effective are octreotide and somastrus in the management of chylothorax in congenital cardiac patients? I would say it's worth a try. Sometimes it's effective, but most times it may not be effective. But I think you have to give it the appropriate dose. What we do in our setup is we first start the child on NPO. We see to it that the chyle becomes clear, and then afterwards start feeding with MCT. And if still that doesn't work, we start them on octreotide. Start off with 2 mics per kilo dose, and then go on up to about 6 or 7, and reduce it if the child does complain of some stomach ache, etc. And generally, if it doesn't work in a week, I think we should start some other lesions, some other treatment. And midodrine is another one which has been advocated as to reduce the lymphatic flow and reduce the chylous leaks. So basically, it's a multiple and a combination of all these which really helps them. And the basic reason for the congenital the chylous leak, if at all, that needs to be taken care of, is most important. On what factors does the long-term survival of patients with unoperated single ventricle heart depend? Well, there could be 2 types really: single ventricles with cyanosis and single ventricles without cyanosis, and a balanced circulation with single ventricles. Particularly if you see is a tricuspid 1 type 1B tricuspid atresia is the best subset. You find they've got a dominant left ventricle, just enough pulmonary blood flow to keep them away from cyanosis. They could move around pretty well, and but all of them at some stage do develop increasing cyanosis because it's an admixture lesion. And once that starts, cyanosis is the dominant thing, polycythemia, which follows that, paradoxical embolism, which follows that, say, brain abscesses, all that. These are some of the problems they face. And associated with that, SVR, which goes up because of the polycythemia, hypertension, LV, the ventricular dysfunction, then AV valve regurgitations. So one thing go, and then before that, rhythms. So if they may lose the sinus rhythm, and they can have other issues. If it is not a pulmonary stenotic lesion, it could be an increased pulmonary blood flow lesion, giving rise to Eisenmengerization, high PA pressures, and with that, they seem to succumb much earlier than the one with the reduced pulmonary blood flow and polycythemic lesions. With these, I come to the end of the questions posed for me, and I thank you for your patient listening, and thank you very much, Right Doctors, for giving me this opportunity. Thank you and goodbye.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.